Can you see it?
Yeah, you forgot to put the logo of DCB Academy, but for this time it's okay. All
Okay.
right, please.
Hi, everybody. I hope you can see the slides. Today I'm going to talk about mechanical thrombectomy in pulmonary embolism. This is a subject and a technique that is not very much discussed in the interventional world. I don't know if every one of you has ever did it. In my country,
So this is a good point. This is we can do a short survey. So first of all, Vakas, do you have experience in doing this?
Professor, yeah, I have done 2 of cases, but definitely we are having a short of equipment in our setup, and most of the time we are thrombolizing these patients. And to be very clear, for thromboembolism, we usually involve the ICU and pulmonology department to look after these cases. So they haven't called us, and they are doing thrombolysis themselves. That's why.
Okay, so manual thrombectomy or mechanical thrombectomy, any type, only 2 cases in your experience?
Yeah. For those 2 cases, one case we have used the ASD device system to reach up to that pulmonary artery, and we did the suction directly from the catheter, because we were not having a dedicated instrument for these. And we were not successful at that time, because we were able to only dislodge few of the we were only able to get extraction of few of clots, but not a major
yeah, that's normal.
And secondly, in my second patient, we have put a pigtail catheter in the pulmonary artery and left for next 18 hours as a direct thrombolysis. And with that thrombolysis, we were having a good results rather than this first attempt.
Yeah, this is something that we have done in a few years ago. The last one was something like 5 years ago, and we didn't have at that time any dedicated device, so we just use, in some cases, the Pronto V10. Pronto is a thrombus aspirator catheter, which is one of the best performing for acute MI, and there is also one version which is 10 French. And with the 10 French, we used to aspirate some of these clots, some of that, because it's impossible to remove all of that. And in other cases, we just use the wire and a pigtail, and with the pigtails, keeping it rotating, we try to fragment more the embolus in order to restore some vessel patency, actually. So this is what we used to do. But I have personally no experience with Penumbra or other devices. And Wojciech, Sylvia, which is your experience?
I don't have my own experience, because I'm not dealing with this, but in my center, we are doing a lot of procedures with ICOS, local fibrinolysis, and mechanical thrombectomy with Penumbra, for example. So we have a lot of patients, more than 50 patients now. So
good, nice.
For example, I don't have experience in pulmonary embolism thrombectomy, but in my centers we have 2 doctors who are doing it, but personally I don't have. The center where Sylvia works, there's the reference center in Poland for those kind of treatment, and there is a big program to treat pulmonary embolism as a thrombectomy with the thrombectomy device. However, in my center there are only 2 doctors who are doing, and we have not so many cases of that.
Okay, thanks. Leo, please.
Okay, so in Romania it's pretty similar. There are a few centers who have Penumbra or ICOS or FlowTriever. There was a center in which I worked. There was a pulmonary embolism shock team, like the MI on call guard. They were going to do the pulmonary embolism, but due to poor finance, now we barely use it in Romania. So I'm going to talk about mechanical thrombectomy based on one case which I participated on its management during a few months of fellowship in Switzerland a few years ago. It is the case of a patient, a man, 51 years old, who had a long history of thrombotic events. The first one, it was an unprovoked pulmonary embolism in 1999. The second pulmonary embolism was in 2000. After 14 years, he had a subarachnoid hemorrhage under vitamin K antagonists, so the anticoagulants had to be stopped. But 2 months after that, he had the third pulmonary embolism. This one was with low risk, with a PESI score of 54, and the neurosurgeons indicated a retake and overlap of anticoagulants, vitamin K, and overlap it with low weight heparin. But the patient had a very labile INR. So in that month, he got tested for thrombophilia, and he had the G2021-0A prothrombin mutation, the factor 2 mutation. What is more, he had a homozygous mutation. And regarding this mutation, is the second most frequent cause for thrombophilia after factor 5 Leiden mutation. It consists of a replacement of a guanine with adenine at the level of at the site of nucleotide to 2021-0A, a factor 2 gene, the prothrombin, which leads to higher level of prothrombin. While the heterozygote mutation has a low risk for thrombosis, the homozygotes have a 3 times higher risk of thrombosis. Going back to our patients, in June 2014, after the mutation was discovered, the hematologist recommended permanent anticoagulation with vitamin K and training with CoaguCheck for optimal INR. And if not, maybe some new oral anticoagulants.
But why? Okay, because at that time anticoagulants were not allowed for this type of mutation. I think this is the reason, no?
Yes, this was an off-label.
Yeah, but what about which was the weight of the hemorrhage, intracranial hemorrhage?
It wasn't very important hemorrhage. It was
okay.
Just a small subarachnoid hemorrhage.
Okay, so he recovered well. All right.
Yes, from 2014 to 2018, he was free of events, but in 2018, he had a thrombotic occlusion of LAD, resulting in a very important anterior STEMI. Unfortunately, I did a presentation on the office laptop, and the movies don't work on this one from home. But it was a very important thrombotic mass in the LAD, in the middle AD, which was stented with one drug-elutic stent, and the patient was put on new oral anticoagulants, rivaroxaban. He had a triple therapy using rivaroxaban, 15 milligrams, taking into consideration that he had previous intracranial bleeding, aspirin for 3 months, and clopidogrel for 12 months. Unfortunately, 1 month later, he had an early in-stent thrombosis, for which he had 2 more DS stents. The doctors who managed the case told me that the second STEMI was almost fatal. The patient was very unstable, and the first stent was keep getting thrombosed, and even the second one got thrombosed during the procedure. So it was pretty unstable. The patient was tested for resistance. I don't really know how it is done, but he had partial resistance to clopidogrel ticagrelor and prasugrel, and complete resistance to aspirin. This is his echocardiogram. Again, he was very young. He had a 30% ejection fraction with large area of akinesia involving the apex and the septum. This is important for the following events. This is his ECG showing the forming of an aneurysm probably. So until 2018, he had a lot of thrombotic events due to his thrombophilia due to the homozygous mutation of prothrombin. He had already 3 pulmonary embolisms and multiple deep vein thrombosis. He had a ST segment elevation infarction with early intrascent thrombosis. He has resistance to aspirin and clopidogrel. He has heart failure with reduced ejection fraction, a history of subarachnoid hemorrhage, sleep apnea, dyslipidemia, chronic smoking. All of the above led to a bipolar personality disorder.
Bipolar personality disorder is, I would say, allowed in this patient, considering his clinical history, minimum.
Yeah. So his treatment at this point was rivaroxaban with ticagrelor, high dose of statin, eplerenone beta blocker, and ramipril.
Okay, excuse me if I interrupt you, Leo. I would like to present you Dr. Hassan. Jazim is a colleague that is practicing currently in France. He's from Bahrain, if I remember well. Jazim, and today he's our host.
Okay, nice to meet you.
Hi, hello guys. Happy to be with you. I wouldn't interrupt much.
Yeah. That's fine. Just to say hello and welcome. Please, Leo.
Thank you very much. Thank you.
Okay, so in 2020, all of his pathology led to acute ethanolic intoxication, drug consumption, depression, burnout syndrome. He quit his job. And in the same month, he had a second acute ethanolic intoxication with several psychotic episodes during the next year with paranoid psychosis, delirium. He was telling that people want to enter his house, but he refused the psychiatry admission or treatment, and which is worst, he quitted his medication, all of it. You can imagine the results. In May 2022, when I encountered the patient, he came back to the ICU with minor cranial traumatism due to a syncope. The CT scan revealed a right subdural hemorrhage and left intracerebral hemorrhage. So rivaroxaban had to be stopped once again. He stayed 3 days in the ICU, and after that, with the Xarelto still stopped, he was transferred in a neurorehabilitation center. However, 1 month later, he had his 4th pulmonary embolism. He had dyspnea for 1 week with low oxygen saturation, and the pulmonary angiotomography revealed a bilateral pulmonary thromboembolism with intermediate high risk. The PESI score was 90 points with severe right ventricle dysfunction. The echo showed 40% ejection fraction with the left ventricle having multiple wall motion anomalies and an apical thrombus, a big one. The right ventricle was mildly dilated, still efficient with a gradient of 30 millimeter mercury. The right ventricle was quite large, so something had to be done. The plan was to put him on continuous heparin with caution with an ABTT around 50-60 seconds and perform percutaneous thrombectomy. and if necessary, maybe an inferior vena cava filter implantation. In this case, the patient was not able to receive thrombolysis. It wasn't the case, to be honest. He was pretty stable. He had a blood pressure of 112, heart rate of 72, but he was very dyspneic with low oxygen saturations. So only on anticoagulants, probably the right ventricle function wouldn't improve very much. So we started our plan, but during the pulmonary mechanical embolectomy, the guide wire went to the left cavities. So what was going on here? The echocardiography showed patent foramen ovale, and probably this was the mechanism for this pulmonary embolism, a paradoxal pulmonary embolism from the big left ventricle thrombus, the apical thrombus. So the plan changed from...
But this is the, I think, third or fourth case of pulmonary embolism in this patient.
Yes, but
So
the previous
you think
ones...
No,
the previous ones were with deep vein thrombosis related. This one is without a deep vein thrombosis.
But how is it possible to it's a contra-paradoxical pulmonary embolism? How is it possible, in your opinion?
Usually when you have a patent foramen ovale with a big thrombus and even mild regurgitation, some pieces of thrombus can migrate in the atrium and go back to the right circulation. That was the logic for what they decided to do at that time.
Yeah, but it's a possibility, of course, but you have also to remind that this patient already had several cases of pulmonary embolism due to deep venous thrombosis, and sometimes it's not so easy to find the right area where the thrombosis was born, actually. So also in this case, he could have had a recidivant deep vein thrombosis. You cannot exclude that.
Yes, I agree with that. And what is more, he could have had an in situ thrombus formation due to his very high risk of thrombosis. But the logic was that if they found it, maybe it wasn't paradoxal, but maybe it should be closed to avoid further strokes or thrombotic events from the in left ventricle. This is the question now. What would you do? Would you close it, taking into consideration?
First of all, you have to manage the pulmonary. First of all, you have to manage the urgency, and the urgency here is that he has a clot or more than one clot in the pulmonary circulation.
Yes.
May I add something? There is one more thing. If in case of PFO, there must be, considering the PFO, there must be recurrent cerebral embolization, recurrent stroke, but he is having a stroke with hemorrhagic conversion, most likely due to anticoagulation effect. So how PFO, this is your incidental finding during the procedure, I must say that.
Yes, it was incidental.
Yeah.
I think that, I was thinking also the same thing that Vaka said. So I would have seen, he had a CT scan. Did the CT scan show, apart from the hemorrhage, also some disseminated embolism or not?
No, at that time, no.
Not at that time. Okay. But then he received another CT scan for that?
After this procedure, 3 months after this procedure.
Okay. Okay, that's fine. Please go ahead.
The plan was to close the PFO, which was discovered at that time, mainly for the prevention of further strokes. This was one of the concerns that maybe
Why for the strokes?
because they thought that maybe some of the previous hemorrhagic strokes were related to embolization of thrombus from the left ventricle.
Okay, if it's hemorrhagic stroke, it's not related to embolism.
Yeah, I know. They thought that maybe because he was under anticoagulation, the ischemic stroke.
Yeah, but in this
transformed-
case, I understand. But in this case, you would have an embolic stroke with an area, an ischemic area in the brain, and around you may have a large hemorrhages due to the anticoagulation.
Yeah.
Yeah,
But in this case, it was a clear hemorrhagic stroke. The diagnosis, from what I understood, it was that. So it
this
cannot
was
be correlated to, yeah. And
Yeah,
the second thing is that if you have a thrombosis of the left ventricle, you're not gonna save for further stroke, possible strokes, if you close the PFO.
Yeah.
Yeah. And the third thing that I have not understood so far is that he was on your table for a pulmonary embolism. So the first thing to do is to manage the pulmonary embolism.
yeah.
I have these 3 points.
I also had these comments, and I asked that I know if I'm not very familiar with strokes, but from which I remember, if you have an embolic stroke, you usually have a big area of ischemic.
Yeah, that's it.
Which you see it on CT scans.
Okay. But okay, let's see. Yeah, we can. I think we can comment in the end. Let's see what happened.
Yeah.
Just please finish the case, and then we can comment.
Okay. Okay, so the PFO was closed at that time.
Okay, we can skip this because we know how does it work.
And then the initial plan was put again on the table. So we use a float river thrombectomy device.
Mm-hmm.
This is a short animation of how it works. If you want, I can skip it. The float
you can leave it.
Yeah, the float river uses a big femoral sheet between 16 French and 24 French, depending on which mechanism you want to use. You can use the aspiration, or you can use the stent retriever. It has the both options. In this case, they used both aspiration and stent retriever mechanism, in which you put on the 0035 guide wire, the stent retriever, and you try to collect as many clots as you can.
Yeah.
What is the size of your stent retriever normally in this case?
Sorry, can you repeat?
Size of stent retriever. This is according to pulmonary artery size, or there is a fixed?
It was a 22 French.
Okay.
Wow.
Yeah, pretty big one. It was pretty remarkable and impressive what they collected from the pulmonary artery. They managed to retrieve a lot of clots, and the patient had an immediate good response with the pulmonary pressure dropping from 35 to 22. Also,
22?
Yes.
Wow. It's a miracle in this patient with a recidivant pulmonary embolism. 22 of pulmonary artery systolic pressure is very low. Because usually these patients, after 20 years of recurrent pulmonary embolism, they develop a chronic hypertension. Yeah. And in this case, it was low because 35 was low, and it became even lower after this. Wow.
And also the right ventricle to left ventricle ratio dropped below 0.7, something like that. The results were pretty spectacular in a few hours already. Also, the inferior vena cava filter was inserted. due to the fact that he had a lot of deep vein thrombosis episodes. He stayed in the hospital for only 10 days and was discharged with apixaban 2.5 milligrams 2 times a day, with having in plan to increase the dose to the therapeutical dose in the long term. Also, long-term inferior vena cava filter, and the rest of the treatment was the same.
Okay.
Also, 1 week later, he had a repeated CT scan, and the aspect was stationary regarding the cranial hemorrhage. At the end of 2022, he had a 3 months follow-up. The patient was in good condition with no further hospitalization or cardiac events. The CT scan showed complete right subdural hematoma resorption. Therefore, the apixaban dose was increased to 5 milligrams 2 times a day, while the venous ultrasound showed complete bilateral iliofemoral occlusion until infrarenal inferior vena cava, but with very good collateralization through grand saphenous vein bilateral. This was the patient. Further on,
Leo, you have, should conclude in 3 to 4 minutes.
Okay. I just want to show you some studies regarding the thrombectomy. Why is it important? It is important to use it in patients in which the thrombolysis cannot be used, in very frail patients, because the clot becomes full of collagen in 2-3 weeks, and the anticoagulants won't be very efficient in these patients. The most important studies using FlowTriever were the FLAIR studies showing 40 pre-procedural and 40-hour right ventricle and left ventricle ratio decrease. And the FLASH study, which was conducted of a Romanian doctor, Dr. Toma, which included 800 patients in the United States. This was pretty spectacular in results, showing on-table hemodynamic improvement with a 24% milligrams pulmonary artery pressure drop. 40-hour mortality and safety outcomes were also very good, with only 1.8 major events and 0.3 all-cause mortality. And during hospital stay, 97% of the patient did not have to receive thrombolytics, only 3 nights of hospitalization, and 62% of the patient had no post-procedural overnight ICU stay.
Yeah, so this is, it seems a miracle also, this slide, but sorry, let me interrupt you a little bit. I would like to ask Amanda. Amanda, are you still there? No, probably she left for a moment. So
no,
I would like to ask.
Here. I'm sorry. I'm sorry.
You're there, okay. So what is like? Did you hear so far the presentation by Leo?
Yes.
So in your opinion, okay, what is lacking from this slide?
Mm-hmm.
So the information that you would like to have, you'd like to have any more information, or this slide is very, is sufficient on the information that it's providing regarding this device for pulmonary embolism?
I think less information.
Yeah, there is one information that is lacking and is very important. Okay, first of all, it's a registry. It will be difficult to do a randomized trial with this device, also because I would argue which could be the comparator arm. It would be difficult. However, if we are talking about the same device that you use in that case, no? This is the same device, the flow trigger,
Yes.
no?
Yes.
Yeah,
Yes.
same size. So you are putting a more than 20 French device in your groin. And also if it's not an artery, but a vein, I would like to understand how high is the bleeding complication in this patient population, because this is a population that undergoes anticoagulation, sometimes thrombolysis. So creating this big hole in the groin is something that would make me a little bit worried. So this is an important information that I would like to have from
Yeah,
this
it's in
study.
the next slide. It's in the next slide.
All right. Okay, great.
The next one. I'll show you the information after I tell you a few words about the ecosystem. It is a catheter-guided thrombolysis.
This is another system?
Yes, it's another system.
Okay.
Using high frequency, low power pulses of waveforms. It was tested in the Seattle studies, which also showed very good results. It reduced pulmonary hypertension and 25% decrease in right ventricle to left ventricle ratio in 48 hours. And also in the Ultima trial, also with good results. Which one is better? We don't know yet. The Peerless study is going to try to answer this question. This trial is comparing the two technologies. However, regarding your comments on primary safety, major bleedings in the FLAIR study were around 3.8%. Major
which
bleedings
study,
were
sorry?
1%. Sorry, 1%, and major events were 3.8%. While in the FLASH registry, the major bleedings were 1.4% within the first 48 hours.
Okay, which type of bleeding classification has been used here?
Honestly, I don't know which one.
No, because this is very important. Because if you use the GRACE, the GRACE classification, 1.4 of severe or bleeding would be, pretty high. If you use the TIMI, it's different. If you use the BARC, it's different. So it would be important to understand which classification we're using in all of these trials, because the ones that have been used so far in the last 15 years are really different and have a really different impact on the outcome. So here, 1.4 is just a number, major bleeding, that seems very low and more than acceptable for this type of event. This is an urgency, sometimes an emergency. You are saving a life of this patient, so you can accept 1.4 is great. But you have to understand, is 1.4 of what? And then also lower impacted, not major bleeding would be important to understand, because also moderate bleedings can impact on the prognosis according to which classification we are using. So this is something that we need to understand very deeply.
Yeah, I don't know the exact classification that was used. And another thing, I don't know if the table 1, which is a comparison of trials for pulmonary embolism treatment, use the same classification in every study. For example, in the PITO study, which used the systemic thrombolysis using 10 hectoplas, the major bleedings were 11% within the first 7 days. So I don't know if it was the same classification as in FLAIR trial, for example.
Yeah. Okay.
One more thing, major bleed, I just want to correct myself. Major bleed, what we know from the circulation, different articles I have read, the drop in the hemoglobin more than 5 gram, or this is a major bleed, and drop in the hemoglobin less than 5 gram, but 3 to 5 gram.
No, Bakas, it depends on which classification you're using.
Okay.
If you're using the BARC, which is the most recent and up-to-date one, or if you're probably it's the one that you're saying, but there are many classifications, and mostly in the studies that were published 5 or 8 or 10 years ago, they use the GASTO, for example. You remember the Gasto classification?
Yes, gastro classification.
Yeah.
Yes.
Then there is the TIMI. So it's very different. For example, there is a discrepancy here. We have in the PATO, we have 11.5 of major bleeding, but mortality 2.4. And here in FLAIR, we have 1% of major bleeding, and then the all-cause mortality is 1%.
Yeah.
So I don't know. It's it's interesting to see all of this data, different trials, but it would be important to have a more similar, to understand more which classification they use.
Okay.
Yes.
All right.
So the main idea from the presentation should be that when we have a patient with intermediate high risk, because mainly this is the case where we can use it. In high risk pulmonary embolism, we usually use systemic thrombolysis. I think this is the standard approach in every center in every country in the world, and only if if it doesn't succeed, maybe we can go to surgery, or if we cannot do surgery, we can use it. But in intermediate high risk patient, we usually start with anticoagulation. But in young patients, I've seen that in Switzerland in some centers, and also in Austria, in very young patients, they are afraid of using systemic thrombolysis for a young patient at intermediate high risk pulmonary embolism, because there is not indicated by the guidelines. So they prefer to use a pulmonary embolism manual thrombectomy when anticoagulation is expected not to work based on the clinical signs and the CT signs. Therefore, we should not forget about this method if it's available in our centers.
Yeah.
Thank you.
Oh, great. Thanks a lot. Thanks a lot, Leo. You showed a very nice case, a very complex one in a patient which I would say was not very lucky. The topic is interesting because it's a bit different from what we usually manage every day. We as cardiologists, but also we in DCB Academy, we don't speak very often about this type of disease. There are, many comments that we can do. We may agree on the management of the case. We may disagree on other parts of it. But in the end, what is important is that the patient went well, at least with a short follow-up after this final event. And thanks a lot for, for all of that.
Yeah.
Are there questions?
Yeah, few things I just want to highlight. This is a very common scenario in our field. One thing is that sometimes patient is on anticoagulation and there is a hemorrhagic stroke, and the neurosurgery or neurologist call us that what to do next, because at the same time we need to give the anticoagulation and there is a bleeding over there, and what is the guideline to restart this anticoagulation, especially in case of hemorrhagic stroke, because this is the area which is, I think this is some deficiency, because most 2 times I came across with such condition, and I try to get the guidelines to how to restart this anticoagulation in case of hemorrhagic stroke, and there is compulsion to start the anticoagulation.
Yeah, that's difficult. Usually they are sick patients. Most of them are oncologic patients. So the prognosis is not very good. One clever thing would be to put a filter.
I see.
Yeah, to put a filter and see if the hemorrhagic stroke is recent. Maybe you can postpone the decision to using anticoagulation after some weeks, according to the neurologist. That's a possibility. Of course, it would be difficult to put a filter obviating totally to the pharmacological treatment, because the filter can get stuck by clots coming one after the other. So it's just a part of the global treatment. But I agree with you that these are very complex and sick patients.
Yeah.
Yes, and another thing is the patients with thrombophilia, the young patients, which are another big problem. While I was preparing this case presentation, I had a similar but not very similar case this week. He died in the end. A 38-year patient came with a anterior STEMI. I stented it. When he got into the back in the room, he had a very early stent thrombosis. He came back to the cath lab. I put another stent, but while I was putting stents, they were just from getting thrombosed, seeing with the eyes. Nothing worked, and I think he was resistant to heparin.
Yeah, that's it.
I,
You have to use bivaliridine in these cases.
Yeah, probably.
Oh, do you have it?
No,
Mm.
we don't have
Yeah,
it.
it's getting.
I tried with after I thought that maybe he has heparin resistance. I tried with enoxaparin, but it didn't work.
No, it's the same. It's very similar. Yeah.
Any
Yeah,
experience
yeah.
of using,
It's yes, please.
sorry. Any experience of using IV cangrelor in these type of patients? IV cangrelor.
No, cangrelor is different. You know, it's an anti. It's not an anticoagulant. It's nothing to do with that. Yeah.
Mm-hmm.
The problem with the acute stent thrombosis is related to the catheter thrombosis related to the anticoagulant.
Yeah.
Cangrelor is an inhibitor of P2Y12. So it's another drug, another class of drugs. Nothing to do. Of course, if you have a thrombosis, an acute thrombosis, you can treat it, but with fibrinolysis, you can try with a GPI if you have it. Hopefully, at least one you should have it. Even if recently I was in a cath lab doing a proctorship, and they said they didn't have anything because abciximab came out from the market because Lilly decided not to do it anymore. Eptifibatide they didn't have, and tirofiban they didn't have. So 0 GPIs. But to prevent thrombosis, you should use an anticoagulant. If you don't have heparin, you should have at least bivaliridine, which is much more expensive and it's not very available after the studies. The BRIGHT, you remember the BRIGHT 2, BRIGHT 3 studies. They came out with discordant results. We can have a lesson on that. Sarah, please take note, because recently everybody's discussing about DAPT, all of that, but that's becoming really boring. I have to say, but an interventional cardiologist must have a good awareness of any antithrombotic in the cath lab. So the lesson could be, if you agree, or please propose something else, but something like antithrombotics used in the cath lab in 2024, so not 10 years ago. So if you don't have heparin, or the patient is resistant to heparin, you should use bivaliridine or argatroban. You know argatroban. It's not very widely used, actually. I've never used it. I just studied it, but that's another alternative. Or fondaparinux. Are you aware of fondaparinux?
Yes.
Yeah, it's another anticoagulant. Actually, we don't have it here in our cath labs, but that's another alternative.
I know that it's indicated when you don't plan a PCI. Can you use it also in patients?
No, you can use it also in PCI. There was a study. I will tell you the name in some Oasis 7. Yeah. In that study, there was an increase in stent thrombosis. It was a randomized trial between fondaparinux and heparin. But the stent thrombosis was related to the guiding catheter thrombosis, which was flashed with a thrombus going into the coronary artery. And it's not a failure, really a real failure of fondaparinux. But at that time, Oasis 7 came out, and so the guidelines said that you should use heparin or bivaliridine in a cath lab. Fondaparinux, if you have an ACS patient, which you manage without invasive treatment. Okay, that's true. However, if you don't have any other anticoagulation that works, you should use fondaparinux because it works. That was a flaw of the trial. It was a 1.9% of catheter thrombosis, which is very high, but was related to the fact that the catheter was not flashed correctly. If I remember well, it's something like 15 years ago.
Okay.
It's history. All right.
Hi guys, I have a small comment regarding the atrial aneurysm. Regarding the PFO. If you hear me well. I don't know what's the practice. I'm not a very expert guy with that sort of procedure. But what I saw in the practice is that they see the characteristic in the echo. So if there is an septal aneurysm or moderate to severe shunt, they consider it as high risk for embolism. And in that term, they kind of tend to close it. And for the another comment regarding the float river, I'm not sure what's the practice because in the mitral clip they use the ProGlide, double ProGlide to close it. It's off-label, but I didn't see much of procedures and float river. We used it 3 times in our center. So I don't know what's your practice regarding the closure of after the procedure. Do you use ProGlide or another compression or?
Yeah, from what I know, if I remember well, we don't do these types of big holes in the veins, not more than 20. I have no experience with this device, but recently, I mean 1 or 1.5 years ago, the ProGlide has been approved also for the closure of the veins. Previously, you couldn't do that. Somebody used to do that with a mitral clip, which actually has also a smaller hole. So if you didn't want to just close with the manual compression, you could use it. But now you can do that also because it's not off-label anymore.
How about the figure of 8 stitch, especially in case of vein? Because I have done that and we have done the figure of 8 stitches and it works well.
The figure of, sorry, what is it?
Figure of 8 stitch. It's a stitch before removing the catheter sheath from the vein. And in this way, we close the vein with the help of stitch.
I don't know the name. I don't know this brand actually. I'm not
Just
aware
a
of that.
stitch is just a stitch 20 stitch, and we just stitch in the figure of 8 manner in the vein.
If you have a case next time, if you want to
I will
do a video and show us, it
make
will
a
be
small
interesting.
video for you. Yeah. Especially
Yes,
when
thanks.
while doing our PTMCs, we are doing figure of 8 stitch.
No, it's nice. I'm not aware personally. I don't know if anybody else is aware of this.
Oh, okay.
But please do a video, and during next lesson, next week, you can just present it.
Yeah.
Thanks. Yeah, regarding the other question by Jasim, it's we can have a dedicated session on indications for PFO closure. We have European guidelines which came out a couple of years ago, and there is also an expert consensus on Eurointervention, which has been published in 2 parts. The first name is Christian Pristipino. He's an Italian physician from Rome. He's a very expert on PFO closure. So we will have a dedicated session, a dedicated lesson on that. But what is important to understand is that since this is not just a topic for interventional cardiologists, usually the decision should be shared with a neurologist and with a clinical cardiologist if to close the PFO or not, because the gray zones are still very high and very large, I would say. So that's important also from the medical point of view, a medical legal point of view.